Good evening, everyone. Today, we're diving deep into a sensitive yet essential conversation. Is being fat a choice? In a world full of polarized opinions, especially when comparing so called fit women versus fat women, it's time we cut through the noise, approach the issue with evidence, empathy, and a deep understanding of the biological, psychological, and societal layers that shape our bodies. As a physician, my role is not to judge bodies, but to understand them. Let's bridge the gap between perception and reality, between shame and science. When evaluating weight management and the concept of choice, it's crucial to recognize the profound impact of socioeconomic status and environment on health outcomes. As a physician, I have worked with patients across a broad spectrum of backgrounds, and what becomes immediately clear is that health is not only a result of personal decisions, it is significantly shaped by the conditions in which a person lives. The assumption that everyone has equal access to healthy food, safe exercise environments, and reliable medical care is not only inaccurate but also dangerous. It perpetuates stigma and neglects the foundational barriers that many individuals, particularly women, face every day. Consider a patient who lives in a food desert, a community with limited or no access to fresh fruits, vegetables, whole grains, or lean proteins. In such neighborhoods, processed, calorie dense foods are readily available and often significantly cheaper than their healthier counterparts. A single mother working two jobs to make ends meet may not have the time, resources, or energy to shop at a store miles away, cook from scratch, or engage in daily structured exercise. In these settings, the idea of choosing to be fit becomes far more complex. It's not about lack of motivation or laziness, it's about logistics, survival, and systemic neglect. We also must address the issue of time poverty. Many women, especially those in low income households, bear the double burden of being both primary caregivers and primary income providers. Between juggling employment, childcare, and household responsibilities, there is often no space left for self care, meal prep, or gym visits. Telling these women to simply make time for their health ignores the real structural pressures they face. It also fails to appreciate the chronic stress that can itself contribute to weight gain via hormonal pathways such as elevated cortisol levels, which promote fat storage and increase cravings for high calorie foods. Education plays another vital role. Nutritional literacy is not taught evenly, and many individuals grow up in homes where processed or fast food is the norm, not by choice, but by necessity or familiarity. If a person has never been exposed to balanced meal planning or taught how to interpret food labels, how can we fairly expect them to make informed decisions? Furthermore, marketing and food industry practices often target lower income consumers with unhealthy options. Sugary beverages, packaged snacks, and ultra processed meals are aggressively advertised and positioned as convenient, satisfying, and affordable. This manipulates consumer behavior and overrides individual willpower. Access to healthcare itself also affects weight related choices. Patients with limited insurance coverage or high out of pocket costs are less likely to seek preventive care or ongoing management for conditions like obesity, insulin resistance, or thyroid disorders. Without professional support, they often resort to unsustainable crash diets or misinformation found online, which can lead to cycles of yo yo dieting, metabolic damage, and even greater weight gain over time. The healthcare gap thus reinforces the notion that weight is solely the result of personal effort while ignoring systemic failures. Safety is another overlooked factor. Many women, especially in underserved areas, do not have safe spaces to walk, run, or engage in outdoor physical activity. Poor infrastructure, crime rates, and lack of public recreational facilities mean that even the most motivated individuals may be restricted in their ability to move freely. Telling a woman in this situation to just exercise more is both insensitive and impractical. In medical practice, we must move away from the oversimplified narrative that weight is merely a reflection of willpower. Instead, we must understand it as an outcome influenced by a wide range of social determinants, factors that are deeply embedded in the fabric of society. If we aim to create a healthier world, we must first ensure that the foundational elements of health, nutrition, safety, time, and care are accessible to all, not just the privileged few. Only then can we begin to talk about choice in an honest and equitable way. In clinical practice, one of the most commonly overlooked contributors to weight gain is the profound and multifaceted influence of mental health and psychological trauma. While weight is often discussed in terms of calories in versus calories out, this reductionist view fails to acknowledge the deep neurobiological and behavioral factors that drive eating patterns, physical activity, and body composition. The connection between emotional well being and body weight is not incidental, it is intrinsic. As a physician, I have seen countless cases where patients are blamed for their weight while the underlying emotional pain remains unrecognized and untreated. Depression, anxiety, chronic stress, post traumatic stress disorder, PTSD, and adverse childhood experiences, ACEs, are strongly associated with the development of obesity. These conditions alter brain chemistry, hormonal balance, and reward pathways in ways that directly impact appetite, cravings, and metabolic function. For example, individuals with depression may experience hypoactivity in the prefrontal cortex, impairing decision making, motivation, and impulse control. When combined with heightened activity in the limbic system, which drives emotional responses and reward seeking behaviors, this creates a perfect storm for emotional or binge eating. Cortisol, the stress hormone, plays a central role in this dynamic. Chronic stress, whether from financial strain, caregiving responsibilities, or unresolved trauma, leads to persistently elevated cortisol levels. This hormonal shift not only promotes fat storage, particularly in the abdominal region, but also increases appetite and specifically enhances cravings for high fat, high sugar foods. These foods in turn stimulate dopamine release, providing temporary emotional relief, but ultimately reinforcing a cycle of emotional eating and weight gain. The physiological feedback loop is not a reflection of weakness. It is a biologically driven survival mechanism gone awry in a modern context. In patients with PTSD or a history of childhood trauma, the effects on weight are often even more pronounced. The landmark AZE study demonstrated a clear, graded relationship between the number of adverse experiences and the likelihood of developing obesity and other chronic illnesses in adulthood. Many of these individuals use food as a coping mechanism, often unconsciously, to manage internal distress. Food becomes not just sustenance but comfort, distraction, or even a barrier, a way to insulate oneself from further harm. In such cases, addressing the weight without addressing the trauma is not only ineffective, it can be damaging. Anxiety disorders also play a complex role. For some, anxiety may suppress appetite, but for many, it leads to compulsive snacking, late night eating, and dependency on food for grounding and control. These behaviors are not easily broken with willpower or simple advice. They are deeply entrenched patterns often tied to unmet emotional needs, fears, and a sense of being overwhelmed. When we ask patients to just stop eating emotionally, we invalidate their experience and further stigmatize their struggle. Sleep disorders, often coexisting with mental health conditions, also exacerbate weight issues. Insomnia, sleep apnea, and poor sleep hygiene disrupt circadian rhythms, impair the balance of hunger hormones, ghrelin and leptin, leading to increased appetite and reduced satiety. Sleep deprived individuals are more likely to consume calorically dense foods and less likely to engage in physical activity, both of which contribute to weight gain over time. And yet, very few weight loss programs address sleep quality as a core factor. Furthermore, the stigma surrounding weight can itself become a psychological burden. Patients living in larger bodies, often experience discrimination, shame, and medical bias, which can lead to social withdrawal, lowered self esteem, and worsening mental health. This cyclical relationship deepens the struggle and can discourage individuals from seeking help, believing that their failure to lose weight is entirely their own fault. In order to support sustainable weight management, we must stop treating the body in isolation. A purely nutritional or fitness based intervention is often inadequate when the emotional and psychological drivers of weight gain remain untouched. A trauma informed, integrative, and compassionate approach, one that includes therapy, stress management, sleep support, and emotional regulation, is essential. Only by addressing the root causes beneath the surface can we help patients heal both physically and mentally and foster true lasting transformation. In modern healthcare, one of the most damaging misconceptions we must confront is the belief that individuals living in larger bodies, particularly women, are inherently lazy, undisciplined, or careless about their health. This stereotype is not only false, it is medically irresponsible. As a physician who works closely with patients struggling with weight, I have witnessed firsthand the intense emotional labor, repeated efforts, and deep frustration that many overweight or obese women carry. Their struggle is not a matter of apathy, but often a matter of misdirection, misinformation, and a healthcare system that has repeatedly failed to offer individualized, compassionate solutions. Many overweight women have tried dozens of diets, from extreme calorie restriction to fat detoxes, ketogenic eating, intermittent fasting, and everything in between. They have often spent years, sometimes decades, cycling through weight loss attempts. For many, each attempt ends in weight regain or plateau, accompanied by guilt and self blame. These experiences do not stem from lack of effort, they stem from biological realities. The body resists weight loss through powerful mechanisms of metabolic adaptation, including decreased resting metabolic rate, hormonal shifts that increase hunger, like elevated ghrelin, and reduced levels of satiety hormones like leptin. In other words, the more they try to lose weight, the harder the body fights back. This is not laziness, it is physiology. Additionally, these women are often acting on poor advice. Much of the information circulating about weight loss in popular media and social platforms is oversimplified or outright incorrect. Eat less, move more is an attractive soundbite, but in reality, it ignores the complexity of human metabolism, behavior, and psychology. When a woman follows a plan that doesn't work for her unique body, whether due to insulin resistance, thyroid dysfunction, polycystic ovary syndrome, PCOS, or past yo yo dieting, it is not a reflection of her failure. It's a reflection of a system that failed to understand her. What's more, many of these women are engaging in health promoting behaviors daily. They are walking, swimming, attending group classes, meal prepping, and journaling. But because their bodies do not conform to the thin ideal, their efforts are overlooked or dismissed. We must remember that weight is not a direct proxy for health. A woman can have stable blood pressure, normal cholesterol, excellent cardiovascular endurance, and still live in a body that society deems unhealthy simply because of size. This bias is not only unfair, it has clinical consequences. Studies show that medical professionals often spend less time with overweight patients, offer less diagnostic testing, and attribute unrelated symptoms to weight, leading to delays in care and worse outcomes. There's also a significant psychological toll. Being constantly judged or devalued based on appearance erodes self esteem, promotes disordered eating behaviors, and contributes to avoidance of medical care. I have had patients who delayed screenings, checkups, and important labs for years because they feared being shamed by healthcare providers. The internalized belief that they are inherently flawed can create a sense of helplessness and hopelessness, which further impairs their ability to engage in long term lifestyle changes. Trauma also plays a role. A significant proportion of women with obesity have a history of trauma, including sexual abuse, neglect, or emotional maltreatment. For some, weight gain becomes a subconscious protective barrier, a way to feel less visible, less vulnerable. When we focus only on the external without addressing the psychological scars underneath, we miss the root cause. To label these women as lazy is not only wrong, it is cruel. It ignores the resilience they display in the face of biological, psychological, and societal adversity. It discredits the emotional energy required to try again after so many disappointments. And most importantly, it undermines our ethical responsibility as medical professionals to treat all patients with dignity, accuracy, and care. Every woman, regardless of size, deserves personalized guidance, evidence based care, and above all, respect. In the discussion of body weight and health, one of the most vital shifts we must make as medical professionals is from judgment to understanding. When we focus solely on numbers on a scale or aesthetic ideals, we reduce the conversation to superficial terms that overlook the most critical factors influencing health outcomes. The idea that we must choose between praising fit women or criticizing fat women is deeply flawed and medically unproductive. Instead, we should be focusing on building a healthcare approach that is grounded in empathy, education, and personalized care, because that is where lasting, meaningful progress is found. Weight is a deeply individualized and multifactorial issue. Each person has a unique combination of genetic, hormonal, metabolic, psychological, and environmental influences that contribute to their body composition. No two bodies respond the same way to food, exercise, stress, or sleep. This is precisely why standardized, one size fits all health advice often fails, and yet many patients are still met with generic recommendations and subtle or overt shaming when they don't achieve expected results. This approach does not motivate change, it creates resistance, guilt, and avoidance. Empathy is not softness or excuse making. It is clinical accuracy. When we listen to a patient's full story, when we understand what they eat, how they sleep, how they manage stress, what traumas they may have endured, and what barriers they face daily, we gain the insight necessary to offer real sustainable strategies. Without that understanding, we risk offering advice that is not only unhelpful but also harmful. For example, telling a woman who is chronically sleep deprived and emotionally exhausted to just meal prep and go to the gym completely ignores the state of her nervous system and the real limitations she faces. Instead, guiding her to improve sleep hygiene, regulate her stress hormones, and build small sustainable habits is more likely to lead to success and healing. Education is another cornerstone of effective care. True empowerment comes when patients are given understandable, science based information about their bodies and health. Many individuals living in larger bodies have never been properly taught how hormones regulate hunger, how gut microbiota influence metabolism, or how inflammation impacts weight. They've been told to count calories, restrict carbs, and exercise more, but not why those strategies may or may not work for them. When patients learn how their body functions and why certain interventions are recommended, they are more likely to engage with their care plan and trust the process. Importantly, personalized care must be the standard, not the exception. Two women of the same weight might have entirely different health profiles. One may be metabolically healthy, physically active, and mentally resilient. Another may have insulin resistance, nutrient deficiencies, and severe depression. To treat them with the same protocol is both medically inappropriate and ineffective. A precision based approach, one that considers labs, lifestyle, mental health, and individual goals, leads to better outcomes. It also reinforces to the patient that they are seen and heard as a whole person, not just a number. We must also reject the false dichotomy that one body type is inherently more disciplined or morally superior than another. Fitness and health are not the same as thinness. And carrying excess weight does not mean a person is lazy, ignorant, or incapable. When we stop moralizing body size, we create space for genuine conversations about health, free of shame, blame, or superficial comparisons. This shift allows all patients, regardless of size, to engage in health promoting behaviors without fear of judgment or ridicule. Ultimately, our job as clinicians is to support health, not enforce a particular aesthetic. Health is not a look, it's a function. It is how the body and mind operate together. It is energy, mobility, sleep quality, hormonal balance, and mental clarity. And those metrics are achievable in a variety of body shapes and sizes. If we are truly committed to helping patients, we must begin by meeting them with respect, equipping them with knowledge, and guiding them through care that is as individualized as their biology. That is not only good medicine, it is ethical, compassionate, and long overdue.